One of the most difficult areas of breast cancer therapy for obviously the patient, but also the oncologist, is the patient that has a recurrence of her breast cancer. One of the reasons that we are so aggressive up front with local therapy, that is surgery and radiation, and systemic therapy being either chemotherapy and or hormone therapy, is in fact to prevent recurrence. The dilemma is that if a patient has a systemic recurrence of breast cancer, and that means recurrence in some organ, such as bone, liver, lung, brain, unfortunately, that is a situation in which cure is not generally possible. The other recurrence that patients sometimes confuse is a local recurrence, for instance, a recurrence in a radiated breast. While this is obviously not a good thing to happen, for the most part, that's a curable situation. The other thing that occasionally people get confused is a new breast cancer in the opposite breast, and I have many patients that seem to think that this is a recurrence of their old breast cancer. An abnormality in the opposite breast is in fact a new breast cancer and would be approached as such. So in a patient with stage 4 or metastatic breast cancer, as I said, our goal, unfortunately, is not cure. So that whatever we do for that patient has to revolve around two goals. One would be to minimize the effects of the cancer, such as pain, weight loss, etc. And the other obviously would be to do the best we can in lengthening that patient's life. Quality of life is a huge issue here, and you don't want to be giving treatments that make the patient miserable, even if they might extend the lifespan by a few months. In patients who are estrogen receptor positive, one should try to exhaust all known anti-estrogen therapies before moving on to chemotherapy. And these might include tamoxifen, several of the aromatase inhibitors, a drug called Faslodex. Estrogen alone, interestingly, can sometimes work in hormone receptor positive breast cancer. But hormone therapies obviously are much easier, less toxic, much cheaper, and also often tend to work better than chemotherapy. So my first rule of metastatic breast cancer is to exhaust hormone therapies if indeed the patient is hormone receptor positive. We are fortunate in breast cancer from the chemotherapy point of view, as opposed to kidney cancer, lung cancer, brain tumors, that we actually do have a number of chemotherapy drugs that actually are quite successful in metastatic breast cancer. In general, short of a patient having a very rapidly progressive cancer, say in lung or liver, our preference would be to use a sequence of single agents. But if patients are rapidly getting sick and having liver failure, for instance, one might use 2 drugs at once. Again, the goal is to maximize life expectancy, but minimize toxicity. Some people on some drugs have more trouble than others, and if toxicity becomes an issue, one can in general move to some other drug. The dilemma, and the biggest dilemma with stage 4 breast cancer, is that at some point, one either reaches a point where we've sort of run out of things to do. Actually, that's not the most common, but we reach a point where the patient and the physician will have to admit that continuing with more chemotherapy is not likely to result in a lot of increased life expectancy. And at some point, the toxicity goes up and the patient is sicker. And at some point, it's just better to have a discussion about discontinuing the chemotherapy and moving into a palliative care situation such as hospice. There are very many variables in how well people do with metastatic breast cancer. Bone involvement and node involvement only carry a much better long-term prognosis than, say, liver or certainly brain. Hormone receptor positivity is always better. If a patient is HER2 positive, then we have the option of a number of anti-HER2 drugs, such as Herceptin and Tykerb, and a number of other anti-HER2 drugs coming down the pike, such as pertuzumab and TDM1. But the reality of stage 4 breast cancer is that ultimately the patient will succumb to that disease, and at some point it is more humane to discontinue chemotherapy than to try to continue it.
Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
about personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.